Good morning. Hello, everyone. This is me, Ghada. Thanks for joining my class, our class today. And please all welcome Dr. Verma, Dr. Ritesh Verma. As you know, he is one of our staff. I asked him to join our class today because he is an oculoplastic surgeon. Just a hint about Dr. Ritesh, he was one of our brilliant candidates. He posted his experience right after he finished his exam, before even the results. And anyone reads his experience, definitely his pass is something sure because he did very well. And after passing the exam, he became one of our staff. He was one of the few who didn't turn their backs on the university and still dedicate some of his time to help other candidates to pass and excel in the exam. All right.
Thank you so much for the wonderful introduction, Dr. Gada.
You're welcome. Thank you for joining us. Sorry for letting you wake up early today on your weekend.
No problem.
Okay. So as you know, this is the last class on Ptosis evaluation. The class today is a bit overwhelming, so be patient, please. I hope you can learn many things today. So we have first some cases from past candidate experiences. And then, so the first part is a bit boring. So please bear with me. And I'm sure that things are going to be better as we proceed. The next part is about the quizzes. And we have at the end some closing slides. And we have additional sections. If you remember in Ptosis classes, I sent you a Google form. It's a kind of MCQs, and they are present on the recorded video as well. Something new today, we have a bit of contest, and also we have a game, interactive game. So let's start with the first one, cases. Here, this is like a simple thing that you may be asked about ptosis in Viva and in clinical stations as well, because this is one of the most commonly cases, clinical day and also in Viva. So as you can see here, this is an experience in Viva, like general medicine and neuro and motility station. Let's see the question. What was the question? A scenario of a simple unilateral congenital ptosis in a child, not severe. So this is like a straightforward question. I'm bringing this experience because you expect to be asked about ptosis even in Viva, all right? And the last question was about how do you manage a case of ptosis in that child? Why they ask about ptosis in this station? What's the importance of asking about ptosis? Because ptosis, you know, is something related somehow to neuro, if we have like paralytic ptosis. But here in this experience, we have like a simple congenital ptosis due to maldevelopment of levator muscle. So what do you think why they ask about this question in this station? What's the primary focus or what the examiner is waiting for in the management here? Because you may think about what? About surgery. Yeah, you are right about surgery. But there is an important thing as important as surgery when we are dealing with ptosis in a child. There is something special regarding management of ptosis in children. Yeah, amblyopia. So definitely the examiner here is waiting for a key word, which is amblyopia. You have to address amblyopia. But since the case here is not severe, so here we are talking about which kind of amblyopia, because we have two types of amblyopia in ptosis when it comes to ptosis. Number one is sensory deprivation, but this scenario is about non-severe. So probably it is waiting for which one, the refractive amblyopia, the anisotropic amblyopia or ametropic amblyopia. So don't forget to mention the non-surgical management of a case with ptosis, like addressing any kind of amblyopia. Don't rush to surgery, all right? Because we have non-surgical management, non-surgical treatment, some lines for treatment of ptosis because of associated findings like refractive errors, okay? So I think this is the message from this question. And of course, don't, memorizing all lines or the surgeries in ptosis. Don't say here, for example, frontalis suspension, because this is wrong. Because you have here what? Not severe, like maybe mild to moderate. So in the discussion, I think they are talking about like a simple case, like not severe case. So you have to, in your discussion, if the case is like poor levator function, yeah, you can mention frontalis suspension. If it is not poor levator function, you have to mention levator resection. So try to tailor the line of surgery choose which surgery fits such a case, such a scenario. All right? Here, this is the primary goal because we are in Ptosis classes, we are talking about a Ptosis case in oculoplastic station. So again, the same scenario, but here you have a real case of bilateral congenital severe ptosis. We have here severe ptosis. So what is the meaning of severe ptosis?
And the lid is covering the pupillary axis, almost reaching the pupillary visual axis.
Can you say it by numbers? Because we keen on numbers in ptosis. When it comes to ptosis,
Yeah, 4 millimeter of ptosis.
Yeah, 4 millimeters of ptosis. Okay, or let's say more than 3 millimeters.
More than 3 millimeters.
Okay, so this is the meaning of severe ptosis. There is an important missing information here.
The MRD one is almost
No.
zero.
Already severe ptosis reflects indirectly that the candidate measured MRD1, okay?
Yes,
But
yes.
the most important measurements in ptosis is missing in this line.
I think levator
You mean
function.
Levator
Levator
function,
function.
yeah, excellent. So levator function, so you have to mention here, but you know, sometimes the candidate didn't write everything. Sometimes he forgot. But as you know, the two most important measurements are levator function and degree of ptosis. So here there is a missing information here, but we expect that like usually severe ptosis coupled with poor levator function, usually, but not always. And the laterality is important in evaluation. All right, so bilateral. So congenital, let's talk about congenital. So usually when you come across a case of ptosis in oculoplastic station, usually the follow-up question will be about the etiology. What is the etiological classification of this case? So in congenital, how we diagnose the ptosis as congenital? We need history. So number one, there must be a history dating since birth or shortly after birth. This is the most important key answer in reaching the diagnosis of congenital ptosis, right? But as you know, in the clinical station, you don't have the opportunity to ask the patient. So what could be other clue for congenital ptosis in the absence of history?
General appearance.
So what do you mean by general appearance?
If on examination, if he looks young or old, in the history, I can ask about the photograph, but
yes.
in clinical, I will see the patient.
Absence of lid crease is one.
But if we are talking in general, we have many acquired causes of ptosis. Even the involutional ptosis, it could be severe with absent crease.
I think bilaterality and young age.
So bilaterality, involutional ptosis is bilateral. Many of myogenic dystrophies are bilateral. Myasthenia could be bilateral, yeah. So you are talking here about young age. So usually when you have a young patient, we think about congenital, right?
Lid lag in donkeys.
Yeah, lid lag is excellent. So if we have a child, is a child equals congenital? So this is true or false? So is it true or false? If we have a child patient in the oculoplastic station, does this equal congenital ptosis?
Most of the time, yes.
Yeah, most probably, but not always, because who knows, maybe child got traumatized and developed traumatic ptosis. So we don't have history, okay? Maybe traumatic ptosis, or maybe this child has a mass and then developed mechanical ptosis. Child is highly suggestive of the diagnosis of congenital ptosis, but doesn't equal all the time congenital ptosis, okay? So let's summarize. We need history or all the photographs, but this is not available in the exam. So you have to convey this information to the examiner. If the examiner asks you, what do you think is the etiology? So regardless of the age of the patient, you have to mention to the examiner, I need to ask about the onset, the age of onset, because it may be congenital, okay? And even if you confronted with an adult patient, like with ptosis, or even if you are confronted with an old patient with ptosis, you have to ask in the history about the age of onset. Because, for example, one of my cousins has a congenital ptosis, but it doesn't bother him, so he didn't seek medical advice, and now he is getting old, and the involutional component is added, okay, you know? So still we have the diagnosis of congenital ptosis, because congenital ptosis doesn't affect life expectancy. So you may have a full-grown man with congenital ptosis. So number one, you have to tell the examiner, I need to ask about the age of onset, because if it is dating since birth, so this is a congenital ptosis, most probably, okay? I don't know if you got the message or not, but congenital ptosis doesn't equal being a child, okay? But the opposite is true. Never diagnose involutional ptosis in a young, because simply involutional means senile, means age-related. So never put involutional ptosis in the differential diagnosis if we have a young patient, an adult patient, or a child, okay? So I would imagine there was some kind of discussion about the etiology of such case, and it turned out to be dating since birth, and that's why the candidate mentioned congenital. And we have bilateral congenital ptosis. Imagine this is poor levator function. Usually the examiner will ask you about the management. Okay, so what would be the management? So again, you have bilateral congenital severe ptosis with poor levator function. Let's say we are talking about a child. So what would be the management? We mentioned amblyopia to be addressed.
First of all, we have to do a refraction.
Yeah, to address the refractive errors and the correction. So when it comes to surgery, is it indicated or not? If we have a severe ptosis with poor levator
Yes, ma'am.
function.
It is indicated after checking all the protective mechanisms, and the patient will need a frontalis suspension.
So name
Severe
the type of surgery. Severe bilateral ptosis
Yes,
with
ma'am.
poor levator function.
Bilateral frontalis suspension surgery.
Excellent. So, and we have here a question about the consent. Let's say counseling. Here about the counseling. What do you want to say to the parents regarding this surgery?
After the surgery, exposure chances are high. So
Yes,
we
cornea.
have to corneal exposure chances are high in these patients. So they have to be, I mean, you have to give them lubricants, and before doing the surgery itself, you have to check all the corneal protective mechanisms, the Bell's phenomenon, everything, and then consent to them regarding the risk of exposure to the parents.
Excellent. Actually, most of the examiners are waiting for the corneal exposure, especially after suspension, because usually there is some kind of lag of thalamus after surgery. So Dr. Ritesh mentioned in the chat about Horner's. I mentioned this in the previous class, that ptosis in a child could be simple congenital ptosis, or we have other causes like Marcus gun, we have congenital Horner, we have congenital third nerve palsy, okay? So be aware that not all congenital ptosis are simple. We have non-simple congenital ptosis due to Horner, third nerve palsy, or Marcus gun, or blepharophimosis, for example. These are all congenital. And remember this, if you reach to the management in the clinical station, this is like a happy ending, because now you have answered all the questions. So usually if the last question was about management, or let's say complications of surgery, you reached the end of the questions. So imagine now another candidate like have a child with severe bilateral ptosis with poor levator function, and he mentioned or she mentioned levator resection. What do you think? This is like a wrong answer, especially when it comes to bilateral. We usually prefer frontalis in bilateral cases, of course, with poor levator function. Let's see the next one. We have 25-year-old male. I don't know how the candidate knows an age exactly, but let's say a young adult man with bilateral ptosis. I added here some information because this scenario was written in other experience. Like we have, again, bilateral severe poor function. I did complete ptosis evaluation, all ptosis measurements. So usually if you confronted ptosis case with ptosis in oculoplastic, you are very, very lucky because this is an easy case. Ptosis evaluation is much easier than proptosis, even in the discussion. So you are very lucky if you have a case of ptosis in the oculoplastic station, because usually they won't see you how do you measure MRD1, how to assess degree of ptosis, how to measure levator function, all the checklist we covered in the previous classes. So as you can see here, the candidate said that she did all measurements. And as you can see, measurements, it's like S, plural. A lot of points to be measured on both sides. So as you can see, I said it's congenital ptosis, okay? Although this is not a child, okay? It's like an adult man, but probably she mentioned to the examiner about the history. probably the examiner told her that it was since birth, for example. How would you consent for surgery in this patient, and what are the complications? So again, about the counseling and the complications. I told at this point, I will do only for cosmetic corrections. You have to be aware of the indication for ptosis surgery. Can you tell me quickly what are the indications for ptosis surgery?
Cosmetic and functional.
Yeah, we usually say functional and then cosmesis, okay? Functional and cosmesis. I don't know why she said only cosmesis, because the case was like severe, and actually she brought this image on her experience. So as you can see, this is a case of severe ptosis. It's covering the corneal reflection. So you have to mention functional and cosmesis. And I will advise patient for frontalis sling, and she blubbered something about the consent part. So, and the examiner were not very satisfied, but you will see that the examiners were willing to pass her. So my time is up, and the examiner stopped me and asked the next part about the question regarding complications. So since we have severe ptosis, again, with poor levator function, that surgery of a choice is frontalis suspension. One of the parts of the counseling that you need to discuss with the patient, the scars, because, you know, after ptosis surgery, there will be scars. So the patient should be aware of the presence of scars, okay? And of course, number one, you should mention exposure keratopathy. So as you can see here, the candidate here missed this information. She didn't say corneal exposure here. So very important before suspension surgery or any kind of ptosis surgery to counsel the patient about the importance of lubricants after surgery, you know, all this stuff to avoid corneal exposure. And as Dr. said, essential part in preoperative evaluation to check the corneal protective mechanisms. What about the complication? Usually, if you have a case like that needs surgical interference, after discussing the type of surgery, okay, usually the next follow-up question will be about complication. So you have to mention the complication of ptosis surgery quickly and by heart. This is like an easy question. But the point is, how do you organize the list? Because complication of ptosis surgery, you will get a long list, but you need to organize the most common and most important, most dangerous at first. So if I ask you, what is the most dangerous complication after ptosis surgery? What would be your answer?
Exposure keratopathy.
Still exposure keratopathy. And if you remember in proptosis classes, we were focusing on two important things, cornea and optic nerve compression, because these are the two sight-threatening complications, okay? So let's see here. She said exposure keratopathy. Now the examiner was happy and he said, go. And he passed her, okay, because she passed the exam. So actually he was waiting for the cornea issue in the counseling, but he got the answer in complications. So what are the other complications? Let's ask you about what is the most common complication after ptosis surgery. And by the way, it's the most common complication after strabismus surgeries, because strabismus and oculoplasty have many things in common. We answer the most dangerous. Yeah, overcorrection or undercorrection. Overcorrection means what? Lid retraction or higher eyelid margin than normal, or we can say than the other side. So you get like asymmetry. And undercorrection, as you mentioned. But of course, there are a lot of other complications. But if you are sitting for an exam, like written exam, and you have a plenty of time, you can organize the complication of ptosis surgery in a totally different ways. You can say intraoperative complication and postoperative complication. You have time, so you can mention all the list. You don't need to organize the most common and most dangerous. But here in our FRCS exam, you don't have such a luxury of time. You have to mention the most dangerous and most common at first. Of course, there are other complications like lag of thalamus, abnormal eyelid contour, bleeding, intraoperative bleeding, or damage to important structure. Of course, you know these complications better than me. So be prepared and try to study the complications and say it quickly. Okay, so imagine that the examiner said, no, this is not congenital ptosis. And we have here a 25-year-old male. Suppose the ocular motility is free, pupils are normal, so no other abnormality. You have just ptosis in this age group. So what could be the other possibilities other than congenital ptosis?
Other parts of myogenic ptosis like muscle dystrophy, myasthenia gravis.
So usually they bring such cases in neuro and ocular motility station. Okay, so whenever you have a case of ptosis in oculoplastic station, usually it's congenital or involutional. So that's why I'm just trying to speculate about the case, but generally, most probably this case is congenital. Okay. But if it is not congenital, usually there will be another finding. As you said, if it is myasthenia, might be some limitation of movement. You know, one of the checklists is to check for fatigability. So there must be, you know, cognitive twitch or drooping of the eyelid on up gaze. Okay. But since this case, this is like 100% congenital because imagine that the other findings are negative. Again, so if you have a ptosis in oculoplastic station, usually it is congenital, maybe Barker's gun, it could be, or involutional. But other causes like neurogenic and myogenic causes, usually they bring these cases in the other station. And we have another station for this, which is neuro and ocular motility station. And that's why I'm saying ptosis in oculoplastic station is an easy case. Let's go to the next one. A scenario of congenital ptosis and jaw winking. So I think this is probably a viva and not in clinical station. Okay, this is actually a viva question, not a clinical station. What is the mechanism and how to treat? Before we answer this experience or talk about this experience, I will return back again to the cyber quiz, because this case scenario in viva station was similar to this cyber question. A 13-year-old female presents with unilateral ptosis as shown in the first picture below. Okay, the second picture is with the patient's mouth open. So whenever the examiner says anything related to mouth movement, like opening mouth, jaw movement, the first thing that should come to your mind is Marcus gun. The best corrected visual acuity is 20/20 right eye and 20/25 right left eye. So the next question, this presentation is consistent with what type of ptosis? We answered this in the previous class. It is
Neurogenic ptosis.
neurogenic. Okay, so this is correct. But we didn't read it in the previous class. So let's read it together.
Marcus gun jaw winking ptosis is a neurogenic congenital ptosis associated with synkinetic movement of the upper eyelid. It is thought to be caused by aberrant connection between the motor branches of the trigeminal nerve controlling the muscles of mastication, that is chewing, and the superior division of the oculomotor nerve controlling the levator muscle.
Okay, so as you can see, you may say between the fifth and third, but it's better to say between the motor branches of the trigeminal. In the previous class, one candidate said the mandibular division. It's like more specific answer. And we talked about the muscles. Instead of saying the third nerve, you can say the superior division of the third nerve or the oculomotor nerve, because you know levator supplied by the superior division of the third nerve. Let's continue here. The synkinesis is due to an apparent connection between levator and which muscle?
Lateral
Is-
pterygoid muscle.
Lateral pterygoid.
Okay, lateral pterygoid. So in some reference, it's called lateral pterygoid or external pterygoid, the same thing, which moves the jaw to the opposite side. It is discovered early when feeding or nursing. So as you can see here, it's almost the same. And here this is a question, it's a basic question. What is the mechanism? And we already answered it. And how we treat it. Let's see the candidate's answer. He said misdirection between third and fifth. So again, it's better to say between the superior division of oculomotor and the mandibular branch or motor branches of the trigeminal. And he mentioned the muscles. He said external pterygoid muscle. The examiner stopped me and asked whether it is external or internal. But the candidate was confident with his answer. He said, I told external. The examiner was confused. So don't worry if there is a kind of confusion, because examiners are human. They may be confused about something. So as long as you are sure about your answer, stick to your answer. Okay? Stick to your answer as long as you are sure. How about the management? Let's read together. I will manage according to levator function. He mentioned the management according to one factor. although the case is Marcus gun. He said, according to levator function, if it is poor, I will do brow suspension. Sometimes we say frontalis suspension. Other reference write down brow suspension. Personally, I prefer frontalis suspension, but both are correct. And if it's good levator function, he will do advancement. Again, some reference say advancement, others say resection. How do you judge this answer? Do you think this answer is an ideal answer?
Retraction.
Yeah,
Amount of retraction.
the wink itself, the degree of retraction. Because this is not simple case of ptosis, this is a jaw winking. We have winking. So in order to decide the surgery, you have to assess the degree of ptosis and levator function, of course, and you have to assess the degree of retraction. And this is well written in Kansky in a very concise paragraph. You can check it out. Here, I think the candidate missed an important part. He mentioned the line of management as if it is a case like simple ptosis, but no, this is a Marcus gun. He didn't mention anything about this insertion of the levator muscle in order to abolish wink. If we have severe wink, we have to abolish the action of levator, right? So if we have severe wink, we have to abolish the levator function by this insertion of the levator aponeurosis, okay? And in order to correct that ptosis, we do brow suspension. Now imagine you have good levator function, but you have severe wink. If you do advancement and resection, you will exaggerate the retraction. And this is a bad outcome. If you have a good levator function and you did advancement and resection, but you have already severe retraction, you will exaggerate the retraction and the patient will not be happy at all with the result. Okay, so please revise this, the management of Marcus gun from Kansky. It's well written and it's very concise. But this is like not ideal answer. By the way, we are here discussing the experience. We are very grateful for those who wrote down their experience. We are not mocking them or criticizing them. We are trying to make a kind of constructive criticism or make the best out of each experience. But the message here, you have to double check. So whenever you have some information in experience, try to double check because sometimes the answer is not ideal answer. Experience is a helping tool, a helping resource, but not a reference. You 100% rely on it.
Yeah, just to add on, Dr. Ghada,
Yes,
if I
please.
can have. So the ideal case scenario for any ptosis with Marcus gun jaw wink is to disinsert the levator and excise the levator till the Whitnall's ligament. Only then you will get rid of the wink. Otherwise, you're not getting rid of wink by any other procedure. And when you have removed the levator, the only procedure left is to do a frontalis suspension or frontalis sling. And this has to be done bilaterally, otherwise there will always be some asymmetry, whether it's a unilateral ptosis or a bilateral ptosis. So it is very difficult to counsel the patient to get the normal eye operated as well. So now what we do is we grade the wink. So if it is mild wink less than 2 millimeters, then directly go ahead and do frontalis suspension because the wink will not get worse and the patient will have good outcome. This is what we do in our clinics, and if it is severe, then the only option left is to do a bilateral surgery.
Okay, thank you, Dr. Verma. But in severe wink, we have to do extirpation of the levator, right?
Yeah, so extirpation, excision, disinsertion,
Okay,
whatever works for you. Yeah.
thank you. Okay, another experience last year, involutional ptosis, because all the features are suggestive of involutional. Like the case was an old man or less old patient, old-aged man, and high lid crease, good levator function. I was asked to do all the measurements and how to treat surgically. So here is the examiner question was like specific about the surgical management. Again, in our clinical practice, if we are talking in general, in order to diagnose involutional ptosis, yeah, we need old age, we need high crease, but we said before it might be absent crease and other involutional changes like maybe dermatochalasis, maybe deep upper sulcus, thin skin, and good levator function. It said that there is mismatch. So usually we have mismatch between the levator function and the degree of ptosis. You may have a case with severe ptosis, but still the levator function is quite good. But are these features only enough to diagnose involutional ptosis? No. You need to add negative of others. What's the meaning of negative of others? I mean, ocular movements are normal, pupils are normal, okay? Patients doesn't have any systemic disease or not on medication for myasthenia. So in order to diagnose any kind of ptosis, you look for the key features of such diagnosis, and you have to mention the negative of others. Now let's answer this question. You have an involutional ptosis. Imagine this is like a moderate ptosis with good levator function. How do you treat it surgically? What's the surgery of choice?
Anterior levator resection.
Levator advancement, levator resection.
Yes. All right. And if you have the patient in the clinical station already, the patient also has dermatochalasis.
Levator resection with blepharoplasty.
Yes. Excellent. And again, you have to counsel the patient. Here, there is no mention about bilaterality, but if we have like asymmetry, you start to by one side and counsel the patient about the need for the second eyelid. So here, this is from Kanitsky 9th edition, because in some references, they say usually it is mild to moderate, but sometimes the involutional ptosis is severe, like in this case, it's like severe involutional ptosis with deep upper sulcus. Here, there is no crease. So we have variation. So sometimes we have one diagnosis, but a lot of variation, like a variety of presentation. So sometimes the involutional ptosis, we have high crease. But in this photo, we have absent crease. There is no crease here. And you may have also thin skin. As you can see, you can visualize the cornea and the iris behind the eyelid. So what's the meaning of good levator function, by the way?
Good levator function is between 12 to 14 millimeter function.
Does anyone has another answer?
More than 10 millimeters.
10 millimeters. I think there is
5 to
some
11, I think.
variation in the references. Okay. And what's the meaning of high crease? What is the average height of eyelid crease in men? You need to check the previous class, okay? Let's move on. This is a case of ptosis. Here the candidate mentioned, I observed apparent right ptosis, no head posture, with corrugated forehead. Then the examiner asked him to do all the measurements. He did all the measurements. Then what is your differential diagnosis? The patient was young, and he mentioned traumatic, surgical. So surgery, post-surgery belongs to traumatic ptosis, okay? And mechanical. I don't know why that candidate didn't mention congenital. I don't know. But when it comes to differential diagnosis, usually when the examiner asks you about the etiology or differential diagnosis or the management, now the examination stopped. Now you have a kind of like viva. You have a kind of discussion with the examiner. So it's okay to tell the examiner about the importance of point to be assessed in history, to be asked about in history, okay? Since we have a young patient, you may ask about the age of onset, as I mentioned earlier. So I don't know, you have to mention congenital. Why the candidate didn't mention myogenic or neurogenic? Most probably because there is no positive findings regarding motility or pupil. So he mentioned only, but he missed the congenital. So this is my comment regarding this experience. Regarding mechanical, we usually describe mechanical when we have a mass or other finding. So if you didn't notice any mass lesion or any sign suggestive of orbital pathology, I think you should not mention mechanical here. And trauma, there might be scars, so you have to be careful about any evidence of scars. But again, in order to diagnose trauma and surgery, you need history again. So usually try to convey your thoughts to the examiner. Don't think silently. Try to show the examiner that you are aware of the causes of ptosis, that we have congenital ptosis and we have acquired ptosis, and we have another system for classification, which is myogenic, neurogenic, aponeurotic, traumatic, and mechanical, and mention this is not involutional, for example, because this is a young patient. This is not neurogenic, and this is not Horner because pupil is normal, and so on. So this is a kind of discussion. But all in all, these cases are easy cases. So the only comment here, you have to add here congenital. Again, sometimes whenever we have a case of ptosis, you have to decide, is it congenital or acquired? Because if it is congenital, usually congenital cases don't require workup, okay? Usually, but not always. So I forgot to mention one of the feature of congenital ptosis. If you have lid lag on down gaze, this is again one of the features of congenital ptosis due to dysgenesis of the levator muscle. Okay, I brought this experience because ptosis was one of the signs, but actually the case is more than ptosis. So if you have ptosis in neurostation, definitely there are other positive findings, okay? Again, if you have a ptosis in neurostation, definitely there will be another sign, at least another sign. It could be in the pupil, it could be motility. Please read this experience for us.
Quickly examine here until you diagnosis patient is uncooperative. I started an observation showing torch. The right eye is severe ptosis, down and out. I asked, can I do cover and cover? The examiner said, no need. I asked, can I do motility? He said, okay, but be really fast, doctor.
Wait a second. So here the candidate was holding a torch. We love very much holding a torch. So be prepared, keep torch in your hand, okay? So she observed what? Severe ptosis. But I think it's not severe enough because she also observed the eye under the ptosis. So she noticed that the eye is down and out. So whenever we have this sweet combination, this combination of ptosis and down and out misalignment, what do you think at this point?
There is motility problem.
I'm asking about the diagnosis. Actually, I rushed at the diagnosis.
Third nerve palsy.
Third nerve palsy.
Third nerve palsy. You think about third nerve whenever you have ptosis and down and out misalignment. And we discussed this in the previous class. In order to confirm your suspicion, what do you need? As Dr. mentioned, we need to check motility. Okay? So motility here is more important than cover and cover. Actually, more important than cover and cover. Cover and cover is just a waste of time because you are not going to operate on such case, okay? Cover and cover for measuring the angle, tailoring the amount of surgery, documentation in order to follow up the patient. This is in clinical practice, in real life situation, okay? In clinical practice. And that's why the examiner said, no need, check the motility because you have the suspicion of third nerve. So motility is the most important at this point. And that's why some advice to check motility before cover and cover test. And that's why the examiner agreed and said, okay, check motility. And I guess she found limitation in the direction of action supplied by the muscles supplied by the third nerve. So what are the muscles supplied by the third nerve?
Levator superioris, superior rectus, medial rectus, inferior rectus.
Okay, what are the extra?
Oblique.
Yeah, you mentioned all the muscles supplied by the third nerve, right? But actually my question was about the extraocular muscles. So if my question was about extraocular muscle, omit levator, okay? Because this is like muscle of the eyelid. These are the muscles supplied by the third nerve, superior rectus, inferior rectus, what else? Medial rectus and inferior oblique.
Inferior oblique.
In other words, all muscle except lateral rectus and superior oblique. And because the lateral rectus is working, we have like exotropia. And because superior oblique is working and superior oblique is depressor, we may have also down position. So the eye is down and out. And here she said restrictions. Personally, I don't like to use this term restriction. I prefer to use limitation, okay? Because restriction, we usually keep this term to restrictive strabismus like fibrosis or like entrapment of muscles, okay? So instead of saying restriction, say limitation or interaction. So back again, you suspected a case of third nerve because we have ptosis and exotropia. Sometimes there is no hypotropia. Actually, the majority of cases are showing exotropia. So whenever you have ptosis or exotropia, you are suspecting of third nerve. So the next step, you have to check motility. What is the second important step to be evaluated if you are suspecting of third nerve?
Pupil.
So, but as you can see here, the candidate somehow like drifted away. She said, I want to check the CAS convergence. So what's the significance here? Yeah, it's a kind of documentation in your clinical practice, in your real life. But here we need to know about the situation of pupil. And that's why he said no, because he wanted to save the time. Then the candidate told, I want to check the pupil. He said, quick look, like examine in hurry. And she didn't notice any anisocoria in ambient light. So there is no anisocoria. Here the candidate said, can I darken the room or turn off lights? He said, no need. Okay, so there is no anisocoria. By the way, anisocoria in third nerve palsy, is it more significant in ambient or photopic or scotopic?
Photopic light.
Photopic light, okay. But since there's no anisocoria in ambient light, what do you think? Definitely there is no anisocoria in dim light. So that's why there is no need for check at dim light, okay? That's why the examiner omitted or refused to do so. So since there is no anisocoria, of course, you know the pupil in third nerve is dilated fixed, as we mentioned in the previous class. So now you have an idea, this is probably a third nerve pupil involving or sparing is like pupil sparing. So he said, finally, he said the diagnosis because the examiner was waiting for diagnosis. He said incomplete third nerve palsy. So incomplete is a bit confusing term. So instead of saying incomplete, you have to say pupil sparing. So pupil sparing is more important. So you can say pupil sparing third nerve palsy. The examiner asked what is incomplete and complete. Okay, so that's why I said this term is confusing. I told without, so this is an abbreviation, without pupil involvement and what?
And ptosis.
But the case has ptosis, I don't know. So in total, so in summary, you have to say this is a pupil sparing, this is your first diagnosis, pupil sparing third nerve palsy. Okay, so the examiner here, what next for her? So whenever we have pupil sparing, we are somehow relieved, right? So she mentioned medical causes in her age, and follow-up is really important. Anything specific to be observed in the follow-up, if pupil sparing convert to pupil involvement, this warranting neuroimaging. Actually, the candidate was giving like broad answers, like what's the meaning of neuroimaging? And that's why the examiner, so remember in the first class in this series, I told you before, be aware of drop-by-drop answer. What's the meaning of drop-by-drop answer? You are not giving the examiner the full answer from the first shot. You are like speaking like few words, incomplete answer, and that's why the examiner re-asking you again. And so the examiner said, why you do neuroimaging? Candice said, looking for aneurysm, posterior communicating artery aneurysm, or any compressive etiology. All right. My question for you right now, what is the imaging modality of choice in such case? Because neuroimaging is a kind of lay person language. Anyone can say, do imaging, do neuroimaging. But you, as an ophthalmologist, you have to specify what type of imaging. If you are looking for posterior communicating artery aneurysm, what is the type imaging modality of choice here?
Magnetic resonance angiography.
Excellent. Another modality?
CT scan angiography.
Excellent. So this is how you can impress the examiner and show off your knowledge because you already know the knowledge. That's why you are saying neuroimaging. This is like a broad answer. Here's the last question. Any other differential diagnosis for this lady? You have ptosis, you have strabismus, and the strabismus here is concomitant due to paralysis, due to limitation of movement. We have limitation of motility. So you have a kind of ophthalmoparesis causing strabismus, and we have ptosis. Number one in your differential should be third nerve. Another one is
Myasthenia gravis.
myasthenia gravis. Actually, the examiner here was giving him or her a clue. This lady. Why is stressing on lady? Because you know it's myasthenia is more common in the females. So finally, I said myasthenia, and whenever you get such smiles, you are at peace. So and says. Here, the examiner actually was educating the candidate and says that's for all nerve pulses and shows way to other examiner. Okay. Actually, he was teaching the candidate whenever we have nerve pulses, you have to incorporate myasthenia gravis. As long as what? Pupil is not affected. Okay. So as I said many times in the previous class, myasthenia gravis in the differential diagnosis of any ophthalmoparesis in absence of pupil affection, in absence of pain, even if there is no ptosis. Even if there is no ptosis. Next. By the way, we have 13 slides about candidate experience. 13 is a lovely number, as you know. So here, a lady with bilateral ptosis. Examine. So don't be surprised if the examiner said just one word, examine, because this is an examination station. Can you read this experience?
A lady with bilateral ptosis examined. I started description in methodical sequence of observation, performed all measurements, special test for ptosis, myasthenia gravis, bells, Coogan's lid twitch. Examiner was keenly observing everything and asked, what is negative MRD?
Okay,
What
answer
is-
it, please. What is a negative MRD? By the way, it is MRD or MRD1?
MRD1.
Because we have MRD2. I know some references, like maybe old references, you will find just MRD, but you have to say MRD1. And you have to know what each letter stands for, margin reflex distance. So what is the negative MRD? 1.
This is when the lid covers the pupil, and you have to raise the lid to obtain the corneal reflex.
Okay, so the lid margin is lower than the corneal reflection.
Yes.
Okay, excellent. And what is the, yeah, keep going.
What is the importance of levator function in ptosis?
Whenever you have a question, please answer it.
Importance of levator function to determine the severity of the ptosis and surgery.
No.
surgical intervention.
Wait. You said the importance of levator function to assess the severity of ptosis. No, the severity of ptosis is assessed by MRD1. Okay. So don't be confused between severity of ptosis and levator function. This is one point, and this is another point. So what is the importance of levator function?
The type of surgical intervention required.
Okay, so try to be elaborative, add more information. You have time.
Okay.
Give me an example.
For poor levator function under 4 millimeters, a frontalis sling would be required, and above that, you would need a levator resection.
Okay. Okay, that's enough. But you can also add the grading of levator function. You can add in your answer the grades of levator function.
Okay.
And why doing Coogan's switch?
To look for any signs of myasthenia gravis.
Okay. Keep going.
Then discussion proceeded to management and surgeries. X was satisfied with all answers, said good, and went with the next case.
It sounds to me this is like a piece of cake case. It's a kind of like undergraduate level. I don't know, but yeah, it's a kind of discussion. So don't be surprised. Sometimes if we have like, they don't have cases, they may bring like an old man or like an old patient, like any worker. Definitely with aging, you will have some kind of ptosis, like mild ptosis. So they may bring such a case just to check how you test for ptosis in general. So you can pray from now to get a case of ptosis in oculoplastic station. And even in neuro cases, like it would be easy also. Can you read this experience, please, for us?
Second case was patient ptosis. Also, he said one word, examine. I started by observation. The patient has no anisocoria or heterochromia. So I think he's ruling out corners here. No abnormal head posture. Ortho in the in the primary position. No apparent proptosis. With apparent ptosis of the left eye.
As you can see here, the candidate mentioned a lot of things. Yeah, he showed knowledge. But this candidate also surprised by one word instruction, examine. So don't be surprised if the examiner was like tough, stiff, and said examine, okay? And you always start by observation. We usually say ptosis on the left side. We don't say ptosis of the left eye. So ptosis is something related to the eyelid. So ptosis of the left eyelid. Okay, keep going.
Left up. No scar of previous operations. The patient has facial asymmetry. The left side seemed to be more atrophic than the right side. This may be facial palsy. You are in the oculoplasty station. Probably the examiner said this, I think. You're in the
Okay,
oculoplasty
so one second.
station.
So now you may get the vibe of this station. I think the examiner
Yeah.
got angry, and that's why the
Yes.
candidate here wrote everything in caps.
Capital letters,
Yeah,
yes.
capital
Yes.
letters. So whenever you get that response, you are in the oculoplasty station. This is kind of a clue, maybe angry clue that you are
Don't
drifted away.
deviate from the
Yeah, you are.
oculoplasty. Yes,
Yeah.
yes.
Keep going.
Why do you say there is facial atrophy? Because of the decreased amount of the cheek fat of the left side. Okay, what is your next step? Measurements. Okay, measure. I measured the MRD in the left eye. It was less than 4 millimeters. He asked me, what are you measuring? I said marginal reflex distant. What does it mean? It means the distance from the corneal light reflex to the upper lid margin. Okay, how to measure it? Show me. I showed him again. Okay. Next, I will measure the interpalpebral fissure height. What does it mean? It means the distance between the margins of both the lids. Okay, show me how to measure. I showed him. Okay, continue. Then the door knocked.
Okay. What is your reflection on this experience?
I think the examiner wants to know whether the candidate is clearly aware of what he's doing. What is the meaning of MRD1 and what is the meaning of palpable fissure height? And he wants to, that probably is checking if we know how to measure it.
That's one scenario. So we can say the take-home message from this experience: don't lose hope, even if you think
Yes.
that you are deviated. Yeah, the examiner somehow got angry or something. You have to show knowledge. Okay, but here instead of saying less than 4 millimeters, I think you should mention the number. Okay, don't say less than millimeters. You have, because you're already measuring, so you have to
Specific
mention
number.
yeah, specific number.
3.7 or 3. Yeah. Okay. Yeah.
But there is another scenario based on, one of the examiners was talking about this before. So one scenario, this is like an easy case. The examiner wanted to assess the candidate's abilities to examine. This is one scenario. Another scenario is that this candidate or that candidate missed an important sign. Okay, but we still have time. So in order to kill the time, and the examiner started to ask simple, easy questions. This is another possibility, but even if you think that you missed a sign and you're no longer able to pick the sign, you have to answer the questions. This is how to show your respect to the examiner. You have to answer the question, even if these questions are easy.
Sorry, I just lost the connection. I rejoined again.
So yeah, I was talking about the other scenario. Maybe this candidate or that candidate missed an important sign. Okay, but there is still time in the station. And that's why the examiner was asking like easy questions in order to pass time. So even if you think that you did bad, you have to answer the questions with the same energy, with the same enthusiasm, because this is a sign of respect to the examiner. You have to be respectful.
Yes.
Read this experience.
A child with unilateral ptosis, and when good eye batched, he had a head lift posture. What is your inference?
Yeah. So can you answer this question?
He had the head lift posture. That means that maybe must ptosis for the other eye.
Okay, let's make it another way. Suppose you have a child. Imagine in your mind now, you have a child or a patient in front of you, okay, with right ptosis.
Yes.
Ptosis on the right side, okay? There is no abnormal head posture. There is no chin up, for example. But when the examiner covered his left eye, the child adopts a chin up position. What does this mean?
That means he's dependent on the other eye for seeing, and he didn't have amblyopia, so that he's, or maybe he has a mild amblyopia, so that he's fixating with the ptotic eye. So, and this is maybe moderate to severe ptosis, so he acquire this position to see.
Excellent. And that's what the candidate said. Actually, I told the child is fixating with the ptotic eye. When is the healthy side covered, now the child is obliged to fix with the ptotic eye, and probably this ptosis is significant enough, and that's why the child adopted this chin-up position. And he asked, what do you think the child has? And I think you answer it also. And this means that that child has amblyopia.
Yes. In that eye, either due to ptosis or strabismic amblyopia, or maybe astigmatism secondary to ptosis.
Yeah, so excellent. Here in this experience, I probably forgot to mention this. I said before, we have two types of amblyopia in ptosis. Actually, we have three types, because number one is sensory deprivation. If we have ptosis covering the pupil, maybe have refractive like anisometropia or ametropia if we have uncorrected refractive error that ignored, or maybe the child developed secondary strabismus because of uncorrected refractive error or because of severe ptosis, so may develop secondary strabismus. So we have another factor, additional factor, which is strabismic amblyopia. How would you treat the child?
How would you treat the child? I will correct the ptosis to prevent amblyopia by excluding bilateral ptosis. Sometimes mild ptosis can flag as normal eye when ptosis in the other eye is severe.
So this is
I think
important in the counseling. So remember, in the counseling, we mentioned before, in the counseling, you have to talk about the cornea, you have to talk about the scars postoperative, okay? And one of the important points in the counseling, that's the possibility of occurrence of ptosis on the healthy side, because it was masked. You know, remember Hering's law? We discussed about Hering's law before. And that's why the candidate mentioned this. Keep going, I will completely
evaluate the case and exclude marked ganja winking and go for frontal sling surgery.
Okay, so most probably this case has unilateral ptosis, which is severe ptosis. Well, let's say with poor levator function. So imagine now the scenario, most probably this is a case of unilateral severe ptosis with poor levator function and congenital. So he needs frontalis surgery. We need to exclude Marcus gun in any case with congenital onset, okay? Because most probably Marcus gun is a congenital phenomenon, generally speaking. Excellent.
I think maybe he missed the pupil in
Okay, pupil and ocular motility.
motility, yes.
I think the candidate checked them, but they are normal, so there was no mention about them because, again, this is an oculoplastic station. Usually, motility and pupils are normal. Okay, but you need to check them, by the way. So you need to check them. But usually, they are normal because this is an oculoplastic station.
Okay.
Can you read it?
Second case, a young female with bilateral recurrent congenital ptosis after previous surgical repair by levator resection, as there was absent crease and evident scars with severe frontalis overaction. Inspect, describe what you can see, needed all signs mentioned, do the measurements I did and he was inspecting. What's your diagnosis? Bilateral recurrent congenital ptosis after previous surgical repair. Can it be under correction? Yes. How to tell apart, is it under correction or recurrence? By history, re-examination. What are the complications of ptosis surgery? I told indication of ptosis surgery in this case.
Okay, so as you can see here, the importance of finding scars. So you have to examine the case carefully, looking for scars at the lid crease or above the eyebrows, looking for scars. But still, the patient has ptosis. So we have two possibilities, under correction or maybe recurrent. So whenever you have an operated case, like post-status case, and still has ptosis, you may think of under correction or recurrence. The question about the complications of ptosis is one of the commonly asked questions. Still, we have ptosis in a patient post-levator resection and severe frontalis overaction. What is the indication of ptosis in this case? He didn't mention the severity, by the way, but he said severe frontalis overaction, but he didn't mention the severity, like mild, moderate, severe. But I guess it was significant because we have severe frontalis overaction. So what could be the indication of ptosis in such case? Yeah, I think you said before. Just imagine the indication of ptosis surgery in general. What could be the indication? In a young
Uh,
female.
Functional cosmetic.
Yeah, I think
Ptosis.
in such a scenario, you have to start with cosmesis.
Cosmesis, because
Yeah,
female.
it's like opposite to what I said earlier, because you have to tailor your answer according to scenario. The patient is still unhappy. But here the candidate mentioned another thing. He said, I told headache due to excess frontalis overaction. Okay, in some areas, in some cultures, I don't know, but some patients don't like to say, I want surgery because of cosmesis. They feel embarrassed to say this. I don't know why. Cosmesis is not bad. We are looking for better outlook, right? To be beautiful and so on. So some patients, get shy or embarrassed to say, I want surgery because of cosmesis. So instead of saying, I want something for cosmesis, they say, I want to do this surgery because it's giving me headaches. Okay. And you can find this expression in glasses. So some patients who are seeking refractive surgery, they say the glasses cause headaches. But if you think again, excess contraction of any muscle can cause headaches. So it's not a bad answer, but I think you should add also cosmesis. Okay. Number 12, experience. So this is a Viva station. But I brought this experience for one thing. So let's read it first.
He gave me a photo and asked me to give differential diagnosis. I said hemifacial spasm and benign essential blepharospasm. Asked for other differential diagnosis. I said maybe blepharospasm due to ocular surface irritation, but it will not involve the whole half of the face like it was on the photo. So he asked, how will you investigate for hemifacial spasm? I said it's mostly due to ectatic vessel compressing the root of the seventh cranial nerve, but in 1% of patients, it is caused by cerebellopontine angle mass, which we should exclude with MRI and MRA. What are the treatment we usually use?
Yeah, answer. I'm hiding the answer, so you can say it.
Lubricants or even Botox injection for this patient.
Okay, Botox. Is it professional to say Botox in the exam?
Botulinum toxin.
Yeah, so this is like a brand name. We try to mention the scientific name. So can you say it again?
Botulinum toxin.
We have different kinds of neurotoxin. Which one?
Type A.
Okay, type A. So let's see her answer. So botulinum toxin type A. Keep going.
Other options, I will refer to a neurologist to prescribe some neurological drugs. No neurologist, only you. So
Okay, so
said,
remember, if you remember
yes.
one of the classes I said before, the last class in Ptosis, I said usually examiners are not happy when you say I'll refer. You have
Yes.
to say I'll refer and mention the line of treatment. So here's the candidate mentioned I refer, but she didn't mention the name of the drug. And that's why he said, imagine there is no neurologist in your area, for example. Okay, so keep going.
Yes. I said maybe improved on carbamazepine. He asked me about contraindications of botulinum toxin. I said pregnancy and lactation. Neurodegenerative diseases like myasthenia gravis and Lambert-Eaton. Also, some drugs interact with it, like aminoglycosides. What are the side effects?
Yeah, answer.
Side effects like ptosis, diplopia.
Excellent, excellent. Here, the order is important. You have to mention ptosis at the beginning because this is the most common side effects of Botox. So I'm saying Botox because we use Botox in my area, but in the exam, you have to say botulinum toxin A. Some use B, but the most common use is A.
Oh.
So I brought this experience because this experience will be very important in the new classes, but here I brought this experience because of ptosis. So the last experience, number 13.
A prepubertal child with right ptosis examine the motility. Can I start with corneal light reflex? No. Can I
1 second. I don't know why the candidate here mentioned pre-pubertal. It's like very specific. I don't know. Maybe he was a teenage. Okay. So this actually in neurostation. It's not oculoplastic station. So again, if I say to you right now, we have ptosis in neurostation, do you expect other findings or no?
I would look for the pupil.
Pupil
Extra
or motility?
motility.
Or motility
Yes.
or both. It could be both. Okay. So you have to be careful about pupils and motility. So we usually start by motility because it's easy, it's external, it's it's manifest, and then pupil. Okay?
Okay.
Here's a candidate, like she was taking a lot of permissions, like, can I start with light reflex? The examiner here said no. Okay, so she was asking about starting with Hirschberg, but examiner said no. Can I check cover and cover? So again, cover and cover for me is a waste of time. He said no. So proceed to motility directly. I don't know, maybe the examiner told her to proceed to motility. I did converge and saccades, and finally the findings at the end. She noticed on motility testing limitation in up gaze, like up gaze in and out, like elevation and abduction and abduction, and hypotropia in the primary position and ptosis. So what's most likely? What is your diagnosis? So let's summarize the findings. Hypotropia, you have hypotropia on one side, on the right side, I guess, yeah, on the right side, hypotropia with limitation of elevation and ptosis. What's your diagnosis?
A third nerve palsy.
Sorry?
A third nerve palsy.
Third? So again, all right. Third nerve palsy
As well as
usually results in exotropia. So the most important misalignment is exotropia. Sometimes the exotropia may be associated with mild hypotropia. Okay?
Okay.
But hypotropia alone doesn't match with third nerve palsy. Okay? So we have here hypotropia with defective elevation. Wait for a second. How do you know there is hypotropia? Here the examiner didn't allow the candidate to use the Hirschberg. So I think she noted hypotropia because it was significant. Okay. This is my guess. Another guess, I usually say try to test motility by pen torch. You can test motility by a target, it's correct, and you can test it by pen torch. But personally, I prefer in the exam to test motility by pen torch, because when you check motility, we start by the primary position. When you check motility, we usually start by the primary position. So you are holding the pen torch at the primary position, quickly do Hirschberg test without asking for any permission. The examiner already gave you the permission to check motility. So check motility by pen torch. You start by the prime position, have a comment on the corner reflection, and notice any decentration of corner reflection or any misalignment, and then check motility. Okay, but I guess it was a significant hypotropia, and we have limitation of motility. The ptosis could be true ptosis or could be pseudo ptosis. How do we differentiate between pseudo and true ptosis?
You can do a cover uncover test.
No, not cover uncover test. We cover the other side. Okay, we cover the other side. So since we have ptosis on the right side, you should cover the left eye. But unfortunately, the examiner didn't allow her to do any cover. Okay, so at that point, we are not sure whether it is true or pseudo. Okay, the only findings right now, we have hypotropia with defective elevation.
Could be a mono elevation defect.
Yeah.
Oh, double elevator palsy.
She said, or he said, double elevator palsy versus orbital blow fracture. Whenever we have hypotropia and defective elevation, the diagnosis should be as follows: monocular elevation deficiency, as you said. And then monocular elevation deficiency could be due to inferior rectus restriction, okay, or double elevator. So you have to mention this whenever you have hypotropia with defective elevation. And then we have under this heading two possibilities: inferior rectus restriction, okay, or double elevator palsy. Because this is important. How do you know whether there is inferior rectus restriction or not? You need to do what? How do you know?
Force reduction test.
Force reduction test. So if you have positive force reduction test, you have to make recession of the inferior rectus. But if the force reduction test is negative, we have a different surgery for double elevator palsy, a kind of transposition surgery to help the superior rectus to elevate the eye. So we have like, we take upper half of the medial rectus and lateral rectus and put it beside the superior rectus. Okay?
Okay.
This is in short. But here the candidate mentioned something interesting. He mentioned, or she mentioned, orbital floor fraction. Because if you study the differential diagnosis, you will find among the causes also orbital floor fraction. But if you think for a while, orbital floor fraction is one of the causes of entrapment of the inferior rectus. So it is something related to the inferior rectus restriction, but of course you have to fix this fraction. Keep reading, please.
So, right, double elevator palsy. This is orbital floor fracture. Okay, it's double elevator palsy. How do you treat inferior rectus recession as a cause of inferior rectus restriction?
Okay, thank you. So as you can see, the examiner agreed on the diagnosis of double elevator palsy, but it's better to say monocular elevation. And as I mentioned, and you have to categorize them according to the results of force reduction test. But again, orbital floor fracture, usually you may encounter such a case in oculoplastic station, and this is a neuro station. But it's no harm of mentioning this in the differential. So the candidate was so sweet, like looking forward to providing any help or advice. So some candidates actually go above and beyond the duty, as they say, and they are very helpful. Not only they wrote down their experience, but also they are willing to help any other candidates. Okay, we finished this first section. Shift to the next one, which will be more exciting because this will be about quizzes. So again, past candidate experiences are treasure, are precious gems, but you have to read it carefully and also skeptically. Don't assume everything is right. Even what I'm saying right now, don't expect everything is 100% correct. You need to double check with your references, your trusted references, okay? Question number 1. So my question is about common theme. You see, common theme. And we have a smiley face here. What is the common theme in all photos? Something like in common.
Malposition.
Good try. Try again.
Okay.
Here. So the common theme here is, we don't say old age because, you know, old age is something.
Evolution.
Okay, so something we always deny. So we usually say involution.
Involution.
The first photo here is an evolutional ptosis. This actually, I don't know the reference, but the up guess here just to show you that good levator function. And here, this is what?
Morgagnian cataract.
Morgagnian cataract.
What's the meaning of Morgagnian cataract, by the way?
Because of the maturity of the nucleus, it sinks down and the cortex is liquefied. So that is what we are seeing here, hypermetric cataract.
And the surgical treatment is a bit tricky and different from the usual cataract surgery. So by the way, it's called the Morgagnian. Do you know what's the meaning of Morgagnian? If you remember Morgagnian, the end letters I-A-N, this is called suffixes. So whenever you have like A-N, like Jordan, Palestinian, Egyptian, Indian, so usually we are referring to a place, okay? Or it could be referring to a person, an important person, like cesarean section. If you remember cesarean section is in reference to Caesar. So it is believed that Julius Caesar was born by cesarean section. So Morgagnian actually is referring to an anatomist or pathologist called something Morgagni. So this is actually the name of the pathologist. So Morgagnian in reference to that pathologist, a scientist's name. Anyway, and here number 3, what is this?
Ectropion.
Make it clear.
Involutional ectropion.
Ectropion, yeah. And you have to say lower lid, right? From the lower lid. And how about this one?
Trichiasis.
Entropia.
Yeah, so as you can see, I brought the diagrammatic illustration to show you the entropion. So this is involutional entropion, and usually whenever we have entropion, we have secondary trichiasis. So the answer for this question is the theme is involutional. So this is actually a test for your observing skills. Speaking of age, if you remember this slide from the first class in this series, be aware of old man trap. So old man or old woman trap, because in old age we get a lot of involutional changes. So be aware that the patient may have involutional ptosis, but they have another important sign, like more important sign like involutional entropion. So don't ever miss entropion in an old patient. So the same applies in anterior segment station. If you are examining an old patient and you found arcus senilis, you found only arcus senilis. Do you think they bring a patient for arcus senilis? No. Definitely, there must be another finding. Although you have to mention there is arcus senilis, but I think this is not important. Double check again, because most probably you will find another finding. Speaking of arcus senilis, if you have arcus in a young age, this is an important sign, not to miss. So you have to differentiate between arcus senilis and arcus juvenilis. Question number 2. I have 13 questions, by the way. Again, what is the common theme?
Lid lag on down gaze.
Okay. So in the first, we have what? Can you say it? Lid lag on down gaze in a case with?
Congenital ptosis.
So this is some of the pathognomic features of congenital ptosis, lid lag on down gaze. And this is a dynamic sign. What's the meaning of dynamic sign? So better to be illustrated in a video.
In a view, yes, ma'am.
Yeah, you have to check up gaze and then down gaze and notice any lagging, any slowing down of the movement of the eyelid. And here, I wrote here a clue, a non-thyroid patient. So this is, what's the name of this sign?
Von Graffi sign.
Von Graffi sign. And the last one?
Surgery, following surgery for both eyes.
What kind of surgery?
Ptosis surgery.
Yeah, what kind of twist surgery?
Frontalis sling.
Frontalis sling.
Excellent. So if we enlarge it this, you will find some evident scars here. Yeah. Excellent. So the common theme here is lid lag on down gaze. This photo was taken from one of the wonderful lectures of cybersite about ptosis. This is the primary position of the same patient. So the scars are more evident on this photo, as you can see here. Here. I don't know, here. So speaking of lid lag on down gaze, I mentioned this slide before and I'm revising it again. So what are the causes of lid lag on down gaze? Von Graffi sign in thyroid patient, some cases of congenital ptosis, and post-ptosis surgery, such as frontalis suspension or maximal levator resection. And I mentioned scarring. Here, I want to elaborate on this slide more. So here, I added 2 additional points. Regarding post-ptosis surgery, actually, this could be one of the complications of ptosis surgery if the surgeon sutured the orbital septum in the sutures. During the suturing of the deep, in levator resection surgery, they do suturing of the levator. If orbital septum is accidentally incorporated in these sutures, you will have such a complication, lid lag on down gaze. Again, if we have an upper lid laceration and while repairing the upper eyelid laceration and you involve the orbital septum in the sutures, you will have also lid lag on down gaze. We have also something called, this is my, I don't know, I tried to make a title, so I wrote this title, lid lag on down gaze like picture. So if you remember, one of the signs of apparent third nerve regeneration, if the patient look down, let's say here, as you can see in this patient has what? A bit of ptosis here and exotropia because of third nerve, but also she developed signs of apparent regeneration. In other words, in looking down, the levator contracts, so it doesn't allow the eyelid to droop as the other healthy side. So this is a pseudo Von Graffi sign and one of the signs of apparent regeneration of third nerve. So if you look at this photo, it looks like lid lag on down gaze, but actually this is not lagging of the lid on down gaze, but it is retraction, okay, like contraction of the levator on attempt down movement. On attempt down movement, because down movement may be limited because of third nerve palsy. Actually, the down movement is not good in this case because she already have a diagnosis of third nerve. So this is number one that gives a picture look like lead lag, lead elevation on down gaze, pseudo von Greve in apparent third nerve palsy. Another pictures here I've shown you before in the previous class in Marcus gun. So with jaw movement, with suckling, the eyelid retract. But imagine now the baby is now looking down. Accidentally, the child is looking down. The retraction with jaw movement becomes evident. So it gives also a picture of lead lag on down gaze. But this is again not lead lag, it's a kind of retraction with the jaw movement. Another one, this patient has involutional ptosis, but it is asymmetric, so it's more on the right side. So if you study involutional ptosis, you will find that in some patients, when they are looking down, there's relaxation of the levator by nature. So when you look down, there is relaxation of the levator. So the ptosis gets worse. And since we have asymmetric ptosis in the primary position, again, in down gaze, there will be asymmetry. So it looks like lead lag, as if this eyelid is lagging. But these pieces of information, just to enrich your knowledge. Question number 3. I mentioned before in the ptosis classes, we have to comment on the eyebrows. And we mentioned 3 points, right? Do you remember the 3 points?
Position,
Yes.
contour,
Yes.
and symmetry.
So level or height involve also symmetry, okay?
Okay. Forehead corrugation.
Okay, this is what I mentioned. So level or height,
Okay.
contour, and any scars surrounding the eyebrows or stitches because of the brow suspension or frontal suspension, the previous surgery, because you may get cases post-status, post-surgery. And I talked about the level and scars, stitches, but I haven't mentioned anything about the contour. I just brought this image, and I told you before this is going to be a quiz. And now it's time for that quiz. So can you name the sign? Okay, how about the contour? Some people have such a contour, but this is a bit exaggerated. Like it's the eyebrow tail here is markedly elevated. It's not never ever something normal. Okay, so what do you think the name of this sign and what that lady underwent?
Botulinum toxin toxicity.
Excellent. This is actually one of the complications of a Botox injection. Somehow the effect is more evident medially. The frontalis is paralyzed here more than here. So we got this abnormal contour. It's called sinister eye contour, okay, because it gives the subject a sinistrous look. Although some people like this look, but for the majority, they don't like this look. And this is one of the complications of Botox injection. Again, don't forget to know the mechanism of neurotoxin, the botulinum toxin A, okay? And try to avoid the area near to levator and lacrimal gland to avoid blepharoptosis, which is the most common complication of Botox injection, and dry eye, respectively. We mentioned the mechanism of botulinum in the previous class. Okay, speaking of Botox, this again from one of the cyber lectures, this lady actually developed ptosis after Botox. Again, I'm stressing the importance of knowing some information about Botox indication of Botox in ophthalmology, contraindications, and complications. So she developed such ptosis after Botox, and as you can see, it's on one side, and we have contralateral lid retraction as a compensatory mechanism. There's additional finding here. He did manual elevation of the ptotic eyelid, and as you can see, now the eyelid on the other side becomes normal. So this is Herring's law positive. But still, she has only unilateral ptosis, okay? Question number 4. A candidate, I mentioned only that there is ptosis on the left side as the upper eyelid level is lower in comparison to the right side. You are the examiner. Would you pass or fail that candidate? And why? I know it's hard for you. Okay, so you are a kind-hearted person. Thank you. You will pass that candidate?
There is an ophthalmos also, I think.
The
There is an
Hirsch's
ophthalmos, I think there is.
Okay, keep going
Is
then. Yeah, dystopia. Finally.
Inferior
Finally.
dystopia.
Yeah, dystopia. Right. So here again, repetition is good practice. I said that before. Hirschberg is central. Thank God there is no squint. And this is the healthy side. If we draw a line like this, what do you think? There is here inferior dystopia, and you can measure the amount of dystopia. So we have inferior dystopia, and as Eben said, there is apparent ophthalmos. And I'm giving now additional photos. Worm's eye view. Definitely there is ophthalmos, okay? The message of this case is, this is ptosis. Yeah, this is a kind of pseudotosis, actually. The eyelid is lowered, but because of ophthalmos, everything is shifted down because of blowout fracture. So don't forget to comment on ophthalmos and proptosis whenever you have a case of ptosis. Especially the oculoplastic station is all about what? Ptosis and proptosis. So Worm's view is very easy because you're going to stand in the front of the patient and just ask the permission to tilt his neck a little bit and look from below, as we discussed before many times in proptosis classes. Whenever we have something red to orbit and ptosis, which one is important is the orbital thing. So if we have proptosis and ptosis, which is important? Proptosis. If we have ophthalmos and ptosis, which one is important? Ophthalmos, okay? Because orbit is most dangerous topic. Orbital pathologies are more dangerous than ptosis, somehow. So here the candidate mentioned only ptosis, which is considered a pseudo, but he missed ophthalmos. If you are the examiner, you would fail that candidate. And whenever you fail a candidate, you have to justify why you failed the candidate because he missed the most important sign, the dangerous sign. Question number 5, correct or false? Hypertropia is one of the causes of pseudotosis. So whenever you see this icon, there is a trap.
False.
Ipsilateral.
Why false? If you say false, what is the correct answer? Make it correct.
Usually the lid follows the eyeball, so
So it should be
if it should be ptosis. If there is hypotropia, then there should be
hypotropia.
pseudotosis.
So let's see the picture here. So as you can see in this girl, so this is one of my cases actually. So if you notice there is some kind of hypotropia and ptosis here. What is the next step? We cover the other healthy side or the fixating side. And now the ptosis is like fully corrected because the eye takes up the fixation. So this is a kind of pseudotosis due to hypotropia. So this statement should be hypotropia, all right? But as you
Hypo.
can see, hypo, yeah, not hyper.
Yes.
Hypotropia is one of the causes, not one of the causes, one of the most important cause of pseudotosis, okay? But as you can see, this is like H here is in lowercase, so this is not the start of the sentence. There is something missing here. What shall we can add before, if we are going to say hypotropia is one of the causes? Can we add some word, an additional word before hypotropia?
Ipsilateral.
Yeah, exactly. So if you remember when we talked about the cause of pseudotosis, we classified them into ipsilateral and contralateral. In order to make a full sentence, you have to say ipsilateral hypotropia is one of the causes of pseudotosis. Ipsilateral hypotropia is one of the causes of pseudotosis, as shown in this photo. Okay? And if you remember, I said, since this is a pseudotosis, so our focus now is what? Is about the motility or okay. Say it.
Contralateral hypertropia is one.
Yeah, exactly. Now, this is a squint case. Okay, so this is not a ptosis issue. This is not a ptosis case. This is a pseudotosis, okay? And now you have to refer such a case. So actually, this was referred to me from a oculoplastic surgeon, okay? So this is not indicate at all for ptosis surgery. Now she has a strabismus issue, strabismus problem. So either in that eye, maybe she has a strabismus on this eye, or maybe the problem on the other side, okay? So let's watch the next one. Actually, without going into much details, okay, because this is not a strabismus class, actually, this child has a diagnosis of fourth nerve palsy on the left side. Now, this is the eye. This is left eye, this is the right eye. Okay, so this is the right eye, and this is the left eye. If we have here fourth nerve palsy, so fourth nerve is the trochlear nerve, supplies what?
Superior oblique.
Superior oblique. So if we have superior oblique palsy, this is actually a depressor muscle. So here the superior oblique here is paralyzed, which is a depressor muscle, and as a result, the inferior oblique, the antagonist muscle, you will have overaction. So the combination of both paralysis of a depressor and overaction of an elevator, the alignment is hypertropia. So we have here hypertropia. And that's why fourth nerve palsy is one of the most important causes for hypertrophy, okay? Sometimes, for some reason, brain decided to fixate with the left eye. Okay, so let's see here. Brain decided to make the left eye the fixating eye. So there will be impulses to the depressor muscle, which is the depressor muscle here, inferior rectus. And again, impulse will go also to superior oblique because superior oblique and inferior rectus are the depressors. So brain is sending excess impulses to the depressors in order to help this eye to take the fixation. But as you know, at the same times, there will be also stimulation of the depressor here, which are superior oblique and inferior rectus again. So what will be the result? Sometimes the eye takes the fixation. So now the left eye is the fixating eye. And the originally aligned eye becomes hypotropic. All right? And in such case, we usually say in strabismus, now the patient is presenting by what's called the secondary angle of deviation because they are presenting by squint on the healthy side. Okay, so when it comes to concomitant strabismus, like paralytic strabismus, sometimes the patient present by the squint in the affected eye, and this is called the primary angle of deviation, or sometimes the patient prefers to fix by the affected eye and they present by the secondary angle of deviation. And if you remember from your medical school, the secondary angle deviation is much larger than the primary angle. So the patient may present by hypertropia, and as a result of hypertropia, there might be a pseudotosis, as in the case that I have just shown you, this one. So actually, this child has a diagnosis of fourth nerve palsy, but she prefers to fix by the affected side, and that's why the right eye is hypotropic. This is a secondary angle deviation, and also we have pseudotosis. So actually, this sentence could be true if we added here contralateral hypertropia. But again, this is advanced piece of information. We will say it in strabismus classes, but if someone asks you about the causes of pseudotosis, you have to say ipsilateral hypertropia, and that's enough. Yeah, don't say contralateral hypertropia and so on, but this is just for you, might help you in your practice. In such cases, we have a problem because you need to convince parents that this is not the abnormal eye is the other eye. So it's a bit of dilemma. That's why I brought this vector. It's like a trap. If you say contralateral hypertropia, now it's correct. But if I'm going to say ipsilateral, you have to say hypertropia. Next question. This patient has severe ptosis. Without surgery, without medication, and without rest, he became like this. Actually, the doctor inserted something in his eyes, and now ptosis much relieved. Yeah, it's improved, but not fully, but a bit improved. What do you think the doctor inserted in his eyes?
Ice pack.
Sorry?
Ice pack test.
No ice pack. So I
Medicine?
have to add ice
No,
pack.
no test.
No rest, no ice pack. It's not myasthenia. Not myasthenia.
Phenylephrine,
No, not myasthenia. Okay, so we have something called contact lens crutches, or to make some improvement of ptosis. And also we have spectacles, like mounted on spectacles. And this one of the lines of non-surgical treatment of ptosis. So if you are asked about the management of ptosis, you may interested to mention there is surgical and non-surgical, okay? So one of non-surgical is crutches, whether mounted on the spectacles or contact lenses. But usually, according to the experiences I went through, they usually ask about the amblyopia and surgery, correction of refractive error, and that's enough. But again, this is to enrich your knowledge. Question number 7. This is a case of marked ganjo winking. What do you expect? What happened to the eyelid behind this occluder or this bar? What do you think?
Winking.
No,
Retraction.
increased ptosis.
Sorry? Increase or decrease?
Increased ptosis. Because in the
Increased.
opposite direction only it will the lid
Yeah. So the winking on the contralateral side.
Yes,
So
okay.
if you remember, so this was a trick. You have to ask patient to, we usually say side movements, but suspect that the improvement or the wink or the retraction or the improvement of ptosis will be on the contralateral jaw movement and not ipsilateral jaw movement. Excellent. Question number 8. Give me a comment about the findings if you have a case like this on the oculoplastic station.
Yeah,
Looks
but
like
that's
mechanical ptosis. Mechanical ptosis due to mass like a plexiform neurofibroma.
Excellent, excellent. And as you can see, it's like significant, and we have contralateral eye retraction and frontalis high arch eyebrows. And if you have a case like this in exam, you have to palpate, okay? Palpate the eyelid and also to avert the eyelid. Here we have another sheet for eyelid swellings, okay? So usually the focus on such case is not about ptosis, because this is a kind of mechanical ptosis secondary to the mass. So usually the focus will be about reaching the diagnosis or differential diagnosis of such mass lesion. So usually the discussion will be about mass lesion and not ptosis.
Yes.
And you need to mention to the examiner that you need to avert the eyelid. Okay, so if you suspect of neurofibroma, like plexiform neurofibroma, what is your comment on palpation? What do you think? What do you expect on palpation?
Bag of worm consistency.
So are you going to tell the examiner there is a bag of worms?
No.
Why?
Because I'm not sure of the diagnosis.
No, I mean,
Embracing in front of the patient, not
you have to use a euphemistic language. This is will be this is one of the recommendation, not to mention any analogies or something related to animals or something non-human. So even if you are feeling a bag of worms, you have to mention to the examiner that the palpation shows signs suggestive of neurofibroma. And if you find that the examiner is insisted on hearing this expression, you can say it's not advisable to mention a feeling of bag of worms in front of patients, just to show him that you know about this expression, but it's not polite to mention in the front of patients. Okay? And sometimes the examiner will take you away from the patient. Sometimes after you finish a case, they will take you away from the patient. So here you can express whatever you like. Question number 9. So mention the findings.
Increased facial show of the right upper lid and increased hyperemia of the lid, the hemiface on the left side with anisocoria and bright light.
Okay, excellent.
So congenital Horner syndrome.
Excellent, excellent. So you noticed the ptosis and the anisocoria. So we have meiosis here, okay, and the flushing, and actually this is called it has a name. So whenever we have flushing,
Harlequin sign.
yeah, Harlequin sign. Excellent. And you have a baby here. Most probably this is a congenital Horner, although there is no heterochromia, so you have to mention to the examiner that there is no evident or no apparent heterochromia. I want you to show the examiner that you know this piece of information. So sometimes you need to mention the negatives. You have to express and show off your knowledge. So even if it is not present, you have to mention there is no heterochromia. Okay?
Okay.
Horner results in mild ptosis. So if you have severe ptosis, this is not Horner. So if you have a profound, severe, like total ptosis covering the pupil, no, this is not Horner, unless it is combined with other pathologies. But ptosis in Horner should be mild, like 2 to 3 millimeters, because molars just responsible for about 2 to 3 millimeters of eyelid lift. But again, if we have a case of ptosis due to Horner, usually it is not in oculoplastic station. It will be in the neuro station. Question number 10. As you can see, this is a desperate man doing ptosis surgery, like levator resection. And whenever we have a surgery, we have steps, right? But according to the experiences, they usually don't ask about the steps. They usually ask about the name of surgery, counseling, in other words, the precaution before surgery, and the complications. Usually this is the scenario. But I don't know, but if I were you, I would have an idea about the steps for levator resection because this is one of the commonly used surgeries. So if you can answer it, who knows the steps of levator resection? I want just the steps until you reach the levator resection because when it comes to levator advancement or resection, we have some steps until you reach the levator resection, and then we have other steps after finding the levator aponeurosis. So what are the steps to find levator aponeurosis? Number 1.
Lid crease incision.
Okay, before lid crease incision. There are 2 steps before lid crease incision.
Informed consent and anesthesia.
There is 1 step before local anesthetic injection.
Informed consent.
Cleaning.
No, surgery after consent.
Cleaning with betadine.
No, after disinfection. There is 1 step before injecting the local anesthetic.
Marking the
Yeah, marking.
Okay.
So if you remember, when we talked about high lid crease, we said this is a kind of academic teaching, but in reality, we mark the crease or we look at the crease height just before the surgery, just before the incision. So number 1 is marking, okay? And number 2, you mentioned injection of topical anesthetic. Imagine now the case is under general anesthesia, like it's like not local. Still, we need to inject something. It's a kind of subcutaneous injection of a medication other than local anesthetic agent. Yeah, adrenaline. So when it comes to oculoplastic surgery, adrenaline is really important, and you have to be aware about the concentration. And these steps actually is important in DCR because DCR steps are important. One of the commonly asked questions about the steps of external DCR. So you have to know about the skin incision in DCR and the injection of adrenaline, and also the gauze that you have to insert it inside the nose to control hemostasis. So examiners are waiting for these points. Be careful. And the next step is skin crease incision. So skin crease is down to the tarsus. So it involves the skin and orbicularis until you reach tarsus. And next step?
Open the septum.
There is a kind of dissection or dissection, and then orbital septum is opened. So orbital septum has to be opened in levator resection. It's not a complication. It's an essential step. And finally, you retract the fat and you will find the aponeurosis, and then you are very happy man. And you can appreciate the steps if you look at this diagram. Okay, I brought this diagram because here, so this is the fat and this is the orbital septum. You open this orbital septum in order to access to the levator aponeurosis, which is behind the orbital fat here. But again, usually they don't ask about the steps, they usually ask about the complications. To make it easier, you can watch videos about the surgery whenever you want to know one surgery. I used to watch oculoplastic surgery by Rick Caesar. They are a bit old, but still gold. They are very clear, like there is like blood-free field. You can appreciate every structure. There's a very skillful and neat surgeon. Question number 11. Okay, spot the mistakes from etiquette points of view.
Standing behind the patient.
Okay, this is number 1. So as you can see here,
Touching the patient.
yeah, who said this? Okay, excellent. Okay, because most of my patients are children, so I usually, yeah, in order to establish a rapport with children, usually there's a lot of touch. So I don't know, but I do this subconsciously. I realize this during the editing. So try to avoid unnecessary touch, especially in some areas. You have to respect the norms, the culture, and religion, and so on. Regardless of the gender, regardless of the age, you have to be careful. Okay. So standing behind, so I justified why I'm standing or moving behind the patient because of the camera, because of the recording. So that's why I usually go behind the patient or the volunteer. But in reality, in practice, we try to avoid standing behind the patient unless needed, and you have to warn the patient beforehand. Okay. So actually, this is taken from my experience because I did the same touch in my exam. So I will read it for you. So another mistake that I want to mention, the case was a young man, and I thought there was a slight fissure. Okay, so I did touch his cheeks. Okay, sorry for spelling mistakes. I did touch his cheeks by my hands to correct his fissure without saying anything like before. The young man got shy, and the examiner smiled at him. So my advice, take care if you are going to touch the patient, ask for permission at first. Question number 12. This is a kind of answerable question, like it's like the answer is already there, but I want to listen to your comments. So before and after upper eyelid taping. And you see the reference is written here. So sometimes even if you are not saying something, yeah, so it's a kind of practice to your speaking because you need such skill in the exam. So try to convey anything, like say something, because you may stuck at the exam and you don't have anything to say, but you have to manage, okay? Instead of thinking silently, try to think out loud.
The superior visual defect is reduced after lid taping.
Yeah, exactly.
Maybe.
So actually, this is a kind of program on Humphrey. It's called the blepharitis screening. The image is not clear because it's old photo. So all these solid rectangles are missing points. The patient didn't see the stimulus in the upper half of the field. Only there is one circle here. This is only seen and this is only seen, but all these points are not seen. And after taping, the solid rectangles becomes like circles. I will enlarge it here. Become like an open center. So this shows that correction of ptosis is important because it will improve the visual field. Why I brought this visual field? To know that one of the indication of ptosis surgery to improve the superior visual field. So now you can add this indication. So we mentioned functional, you mentioned functional because the amblyopia, right? And we mentioned cosmesis. You can also mention improvement of the visual field, okay? The superior visual field. Because if you remember, we mentioned in the first class on ptosis, the sequence of, or the sequela of ptosis. One of the sequela of ptosis is compromising the visual field, the superior visual field. So this is a kind of documentation or to justify the importance of surgery to improve the superior visual field. Okay, so the last question, question number 13. Fill in the gaps, mostly yeah, we can say visual defect. Yes, it's a visual defect, but we usually say lid artifact. So again, this is important, and this is to show you the importance of considering ptosis before visual field testing, okay? Because it may give you false impression of neurological problem or anything, but actually this actually an ophthalmology resident who have a prominent superior orbital rim. It's not ptosis, but ptosis creates the same artifact. Thank you all. We finished the second section. The third one is a game. Okay, so as you can see, there was a slide about lion's face. Now we have a lot of lions running behind you. So imagine this situation. Or you walked into the lion's den. The only way to escape from them is what? Is to be fast, right? To be swift. So the following game, the interactive game, is about swiftness, to be quick. It's a practice to be quick. To be quick in two things. In thinking, because you will have a question and you have to think about the answer, and then you have to click on the correct answer. So it's a kind of practice your swiftness in thinking, or how quick you are in thinking and in responding, to respond fast or quickly. Ready? So I sent a link. You go to this link using your phone. Is that clear? Now you are using laptop. You are seeing my screen from your laptop. The Zoom is in your laptop, but you need to use your phone to access to Kahoot website. Or you can type on the Google Kahoot Play. How about it now?
Okay, we see that.
Yes, yes. You can put any name.
Yeah, you can put your real name or any name. By the way, you can change your avatar if you like. And
That's cute.
okay. Much
Oh.
cuter. Still man is missing. So we have now 4 participants. I don't want anyone to speak out or like to read the questions loudly.
Yes.
Okay.
So the first question is going to be a demo. You are going to play from your phone, but you are watching my screen on your laptop.
Yes.
Okay.
So it's called Ptosis game. And you have to be swift because every question is 5 seconds. So MRD1, so you have to write in your silently and answer. And you have to click on the answer.
Oh, okay. The time's up. Okay.
Okay, it's only 5 seconds. Okay.
Okay.
So
So you have
this,
to answer on the phone.
yeah, you have to look
Okay.
at the screen from your laptop and answer on your phone. So see how it's difficult. Okay.
Okay, got it. Yeah.
So what is the question? I will read it, but the next question you have to read it silently. So MRD1 is 0.5, so the degree of ptosis is mild or moderate, severe, or normal. So the correct answer is severe. So only 2 participated in this question and 2 didn't. Because this is like a demo, there is no points. So you have to answer correctly and faster. If you both answered correctly, but one is faster than the other, the fastest one will be at the top. So be ready because the next question is coming.
Okay.
Okay, we have 3 answered the question. Let's see. Measuring the MRD1 with mitigation of the action of frontalis. You remember we mentioned 2 techniques for measuring the MRD1. You ask the patient to look down at first and then at the primary position. Listen to next. So lid excursion is 5, so the levator function is fair.
Fair.
Okay, this is the correct answer. Let's see. The next, be ready. All the following are cornea protection mechanism except Jones testing. This is the correct answer. The chart is still the first, okay. The most likely outcome following inadvertent suturing of septum in subcutaneous tissue when repairing eyelid restoration is lid lag on down gaze. This is the correct answer. Then switch it to the top. So be careful, doctor, the next time. Next. The primary abnormality seen in simple congenital ptosis is in the muscle. So still Stephen has the highest answer, streak. The primary abnormality seen in ptosis after cut surgery is aponeurosis. So after cut surgery, we may get aponeurotic ptosis. This is the correct answer. All
Yeah.
answered. Finally, okay. And this is why practice makes you perfect. So at the beginning, yeah, you need to practice. So this is like the message from this game. So over time, you will be faster and more professional. So between, of course, elevator and fifths, this is the correct answer. I don't know, someone mistakenly chose a wrong answer. Next. Only 2 answered. I don't know why, but it's ptosis, the most common complication. By the way, if you want to play smartly, you have to expect the answer before the appearance of choices, okay? It's true. In acquired myogenic ptosis, usually the ptosis correlate well with the degree of elevator function. The next question is the last question. So again, the last 2 questions were what? True or false? This again to teach you the importance of being attentive to the questions asked. You have to read carefully. Is it a multiple choice question or is it true or false? On the other hand, in aprotic ptosis, usually the ptosis doesn't correlate well with the levator function. We maybe have severe ptosis, significant ptosis, but still the levator function is good. Okay, thank you. Let's return to our presentation. The next part is the contest. As I said before, we have like black horse and white horse. Black horse is going to talk about congenital simple ptosis. So be careful about this expression or this term, congenital simple ptosis, because we have sometimes congenital Horner, congenital third nerve, as I said. And white horse is going to talk about involutional ptosis. Dr. Van, she's having her exam, I think, today. So she sent her PowerPoint. She did great on the PowerPoint. So I'm going to talk about the involutional ptosis, and Dr. Musa is going to talk about congenital simple ptosis. Okay, here it is a test to stick to the requirements. So the maximum adequate time should be at maximum 5 minutes, and you should have only 5 slides and 1 sentence on each slide. Photos are needed, no videos. And as you can see here, I brought the picture of Bill because time is crucial. Your exam is time bound. You have to answer fully and correctly within a time limit. So are you ready?
Yes. Okay, I'm presenting congenital ptosis, simple congenital ptosis. Most important, the definition is congenital weakness of the levator superioris. The assessment is by history, onset. Onset usually will be from birth. Is it unilateral or bilateral in the history? What is the vision and visual affection? Any previous surgery? Any family history of similar condition? Any systemic association? Also, I will ask about any systemic condition, bleeding disorders, any previous complication with general anesthesia. On examination, most important, best corrective visual acuity. On an inspection, usually will be, it can be severe, mild, moderate, but usually will be severe ptosis, either a bilateral or asymmetric ptosis. It can be also unilateral. I will inspect the skin creases will be absent usually in simple congenital. Also an inspection of any scar of previous surgery, inspection of any head tilt or chin up position, measurement, most important MRD1, margin reflex distance 1, levator function, other. Also, most important corneal protective mechanism, extraocular movement, pupils. So here a photo comparing the degree of ptosis by examining the MRD1. I will grade the ptosis into mild, moderate, severe according to MRD1. Also the levator function or upper lid exclusion, either normal, good, fair, or poor. This will be important in the type of surgery. So the management, generally management will be observation in mild cases. The surgery, the determining of timing of surgery early if there is amblyopia, astigmatism, any head tilt or chin up position. Later on also if there is any psychosocial purpose, the surgery can be delayed up to 5 years of age for accurate measurement if there is no amblyopia. Most important is counseling about complication. I will tell the parents that sometimes there be under or over correction. Also, it can be other complication like infection, granuloma. Also, maybe there will be ptosis of the other eye, lagophthalmos, especially if frontal sling is the surgery. This is the diagram showing management of ptosis in general, not only congenital ptosis. It will depend on the degree of ptosis and the levator function. In general, if it is mild ptosis with good levator function, I will do filinephrine test. If it is positive, I can do myelorhexectomy. If it is negative, I can do levator resection. If it is moderate ptosis with fair levator function, I can do maximal levator resection. Or I can do conjunctiva. I can do frontal sling. If it is severe ptosis with poor levator function, or even moderate ptosis with poor levator function, the only option is frontalis sling, either unilateral or bilateral, according to the ptosis. And some surgeons prefer bilateral approach in all cases of congenital ptosis.
Thank you. Be careful again. If you have a case in front of you, don't mention all the surgeries. Suppose you have a patient with moderate ptosis with fair levator function here. Don't mention to the examiner about the phenylephrine test because it's not relevant. This is only for minimal ptosis with good levator function. Okay, so you have to choose the proper surgery according to the findings in the case. Or if we have a photo in Viva, according to the findings on the photo. Never mention frontalis suspension in a case with good levator function, for example. Okay. You did great. Thank you so much. Very informative. And here you should add degree of ptosis. So MRD1 in order to measure the degree of ptosis. And here you missed complication of the cornea. And
Yes.
Please don't forget it. And you mentioned early interference if we have astigmatism. If we have only astigmatism, yeah, simply corrected by glasses. But if we have sensory deprivation like significant ptosis covering the pupil, you have to interfere early. Some of my colleagues do surgery for severe ptosis after 6 months. Even if the child is adopting a chin up, this will have a detrimental effect on the neck muscles, so you have to interfere early whenever you have a severe covering the pupillary axis or the visual axis. Sometimes some references you like to make a table as a comparison between congenital ptosis, simple ptosis of course, and involutional ptosis. Congenital is since birth, but involutional something acquired with aging. Number 2, the age of onset. Remember, the age of onset and not the age of patient. So the age of onset is with age in involutional, but the age of onset in congenital ptosis since birth. In involutional ptosis, we have good levator function and mismatch between the levator function and degree of ptosis. Usually, we have moderate, significant ptosis, but with good levator function. But in congenital ptosis, usually, if we have a severe ptosis, usually with poor levator function. Regarding the red crease, here is high red crease, may be absent. In congenital ptosis, it varies. And you have to mention the negatives. So no affection of the pupil, no affection of motility, no other findings suggestive of any systemic disease in either of two. We have two parts, the closing slides. So again, as you've seen in the previous canned experiences, sometimes they ask you about how do you examine. So practice every step carefully and do it quickly and correctly. I added here some points not relevant to the exam. So you will never avert the upper eyelid, for example, or do phenylnephrine test or other pharmacological tests in Horner, but I wrote them in order to study them well. I added a lot of points regarding corneal protection. The most important builds lack of thalamus, orbicularis, corneal sensation, therapeutics uptime, staining, Schormel, and also the lid lag on down gaze. The most two important points to be measured, MRD1 in order to determine the degree of ptosis and levator function. If you have to choose one, I will choose levator function. And of course, you have to do these points on both sides. Regarding the etiological classification, here, don't forget iatrogenic causes. As I said before, after Botox, for example, or if we are doing surgery in the eyelid, if we have a case of upper eyelid retraction. So we have surgeries for upper eyelid retraction. If we have overcorrection, you will get ptosis. So don't forget iatrogenic causes as well. After surgery, it could be mentioned under the heading of traumatic, like after cataract surgery, you may get aponeurotic ptosis. And the exact cause is unknown, maybe due to of the speculum, pride suture, or hematoma due to injection of anesthesia. Here is an important piece of information. If we have a child with congenital ptosis, we usually feel relieved, okay? But if we have an acquired ptosis in a child or unexplained mass in the eyelid, so if we have an explained mass in the upper eyelid or acquired ptosis in a child, you may think of orbital pathology. So you need to do imaging of the orbit, okay? It could be rhabdomyosarcoma or any other orbital mass, especially if there is a hidden proptosis also. And if you remember this slide, this patient has a ptosis, but also has proptosis due to orbital cavernous hemangioma. So whenever we have ptosis and proptosis, our primary focus is on the proptosis. Okay, of course, you can mention to the examiner the ptosis, but here mostly the discussion and the evaluation is about proptosis. And don't forget, sometimes if we have a ptosis, can mask proptosis. And that's why I usually advise you check Worm's view. So this is another case of ptosis, and you may think there is no proptosis, but actually this child has proptosis, but it's masked by the ptosis. If we do Worm's view, you can appreciate the proptosis. This child has optic nerve glioma, and the fundus change blurring of the disc. This is taken from the Ophthalmology Secrets. Although the history is not taken in the exam, but you have to keep in mind the points to be asked in a case of ptosis, because you may say this to the examiner in the discussion part after finishing the case. So let's answer it quickly. What is the importance of age of onset, for example? Congenital dating since birth, diurnal variability because of myasthenia, for example, jaw movement because of Marcus gun, any diminution of vision, amblyopia, spectacles, any diplopia. So diplopia may be because of myasthenia causing ptosis and misalignment. Contact lens RGP because it causes aponeurotic ptosis. Other family members like blepharophimosis syndrome, past history of trauma, past history of surgery, history of medication for myasthenia, for example, or also medications that might cause bleeding tendency during surgery, like aspirin, non-steroidal, NSAID. You have to inquire about these systemic disease like myasthenia. So you have to keep in mind some points to be asked in the history. All right. About variable ptosis. So ptosis may be variable according to the time of day because of myasthenia, according to the years like chronic progressive external ophthalmoplegia, according to temperature like ptosis improved by ice cold in myasthenia. Medication for myasthenia will improve the ptosis. Jaw movement causes variable ptosis because of retraction with jaw movement, so it's variable. Hearing is low will affect the degree of ptosis on the other side. According to the gaze, for example, the ptosis might improve on down gaze due to lid lag as in congenital ptosis, or may get worse on down gaze as on involutional ptosis, or may get improved on, let's say, adduction or depression, like in apparent third nerve regeneration. Okay. Ptosis and palsy. So we mentioned palsy. So ptosis with palsy, you may think of third nerve palsy, sympathetic palsy, which is Horner syndrome. Also facial nerve palsy caused brow ptosis and pseudotosis. And also we mentioned double elevator palsy. So this is like a slide about combination of ptosis and palsy. We usually in medicine, when we convey the findings, we usually say the positive findings, then the negative findings. So we usually in medicine, they taught us that to mention the positive findings and the negative findings. So let's read this example. A 47-year-old diabetic patient developed an acute right side profound ptosis and exotropia with limitation of movement in the direction of action of muscle supplied by third nerve. And also this patient has bilateral posterior subcapsular cataract with non-proliferative diabetic retinopathy and no other findings. This is like a humble, or let's say not professional answer. Why? Because whenever we have a third nerve, you have to tell me about the pupil, even if it is normal. You have to tell me pupils are normal. This is important. So even the pupils are normal, you have to tell me the pupils are normal. You have to mention specifically the negative findings. Because I don't know, maybe you didn't check pupil. Maybe you forgot to check the pupil. Who knows? So you have to show me that you check the pupil and you find the pupil normal. That's why we have to mention the relative negatives. There is another more professional way, and that's why it's called an art, to elicit your symptoms, your findings, to mention the positive important findings, and then the negatives important, like relevant, and then go back to the other positive and the other negative. Giving you an example, the same patient. A 47-year-old diabetic patient developed an acute right profound ptosis with exotropia and limitation of movement. And then I mentioned the negative relative, no anisocoria, no other cranial affection, no pain, no signs suggest of high intracranial pressure. Because whenever we have a third nerve, we want to know, is it pupil affected, evolving or sparing? Is it isolated, or there is other neurological findings? So as you can see, I mentioned here some negatives because this is really relevant to the important diagnosis, which is third nerve. And return back to other findings that not urgent, like cataract and diabetic retinopathy, and no other remarkable findings. So this is another method to convey your findings. This is a slide I mentioned in the first class, what are the signs of poor levator function and its significance. And we said two. Poor levator function means that the upper lid excursion is 4 millimeters or less, or absent crease. And what's the significance? Because we can't do levator resection, we have to do frontalis suspension whenever we have a poor levator function. But here you see I inserted a vector of bomb besides absent crease. Absent crease doesn't always mean poor levator function, because give me an example in involutional ptosis. If you remember, involutional ptosis, we have good levator function and absent crease. Sometimes we have absent crease in involutional ptosis. So absent crease, yeah, it's a sign of poor levator function, usually in congenital ptosis, but it could be absent crease in involutional ptosis with good levator function. We have another fancy sign for poor levator function. This is a fancy, not important, don't mention it to the examiner, but it's written in some references, which is called LF sign. What is LF sign? The examiner everts the upper eyelid and you ask the patient to look up. Normally, the eyelid should flip back. But if the patient has a poor levator function, it will stay averted. This is called LF sign. Not important. Be careful about the difference between blepharocharesis and dermatocharesis. For example, which of the following may serve to distinguish blepharocharesis from dermatocharesis? The most important is the age of onset. Blepharocharesis is young, but dermatocharesis in aged population. In blepharocharesis, we have recurrent eyelid swelling, and we might have herniation of the orbital lobe of the lacrimal gland. We have other findings, so try to differentiate between both. But be aware, they are causes of pseudotosis, but they may be associated with true ptosis. Even if there is no ptosis, this excess skin will affect the superior visual field and they need to be corrected. Also for cosmesis, they deserve a good look, so they indicate for surgery. So be aware of oculoplastic syndromes. We mentioned in our classes 3, Marcus-Gann-Johansson syndrome, blepharomosis syndrome, and floppy eyelid syndrome. Floppy eyelid syndrome is also important. Regarding phenylephrine test is not only for cases with Horner diagnosis, in any case with mild ptosis and good levator function. Regarding your standing position, in the exam, usually in oculoplastic session, you will be standing by convention on the right side of the patient. But sometimes you need to stand in front of patient while doing Hirschberg, while doing the ocular motility cover test, you have to stand in front. And sometimes you have to move to the left side in order to do such test on the left side, like levator function. And in proptosis, if we are going to do Nafziger, you have to stand behind the patient. The final part is the Google form. And as you know from proptosis classes, it's a kind of a link. I will send it. It's a kind of MCQs to test your overall knowledge on ptosis. You will find your score at the end and you will see the feedback for each question. The question were taken from American Academy Network. I really like this source, and also Massachusetts Ophthalmology. Yeah, we finished ptosis finally after 4 classes. The next class is going to be about entropion, especially if you're center in Cairo. So entropion is really important. So entropion, we have 2 classes in oculoplastic classes. So we have only entropion, and the last final class, like an overview about the other topics. Okay, thank you all. You are very patient and very determined. You made it until the end of our presentation. Thank you all. I really appreciate your dedication to the class. Thank you.
Thank you, Dr. Gara, for your time. Really appreciate it.
You're welcome.
Thank you so much.
You're welcome. Bye-bye.
A 25-year-old man is seen in your office 2 months after blunt trauma to the right orbit. The examination is normal except for blepharoptosis on the right side. Levator function is normal on both sides, and the patient states the eyelid positions were equal on both sides prior to the injury. There is no anophthalmos, and the patient does not complain of diplopia. What is the best next step in managing this patient? Surgical exploration and repair of the levator aponeurosis. Close observation with no plan for surgical correction until 3 to 6 months after initial injury. Computed tomography scan to rule out an orbital fracture. A tensilin test to rule out new onset myasthenia gravis. Blunt trauma to the orbit commonly results in edema and ecchymosis to the periorbital soft tissue. These latter processes may result in stretching, dehiscence, or disinsertion of the levator aponeurosis. It is difficult to correlate the degree of injury to the levator aponeurosis with the severity of blunt injury. Younger patients tend to have enough elasticity in the tissue to allow significant, if not complete, resolution of the blepharoptosis. However, for all patients, blepharoptosis from blunt injury should be allowed the opportunity to spontaneously resolve without early surgical intervention. Patients should be examined monthly for changes in the eyelid position. If no improvement in eyelid position occurs by 6 months after the injury, it is unlikely that any improvement will occur in the future. In this case, surgical correction may be planned. However, if improvement is noted on a month-to-month basis, then surgery should be delayed until improvement reaches a plateau or all blepharoptosis resolves. A CT scan is helpful in evaluating injury to adjacent bones. There is no evidence of injury to orbital bones based on the exam. There is no diplopia or anophthalmos. Given the history of blunt trauma, it is unlikely that a tensilin test is warranted. Myasthenia gravis should be considered in the diagnosis of adult blepharoptosis in the absence of other predisposing factors. A 75-year-old woman complains of restriction of her upper field of vision and difficulty reading when looking down. She denies any discomfort, epiphora, or diplopia. Her vision is J1+OU through her well-positioned bifocal segments. A basic tear secretion test is normal. Examination shows an eyelid malposition. What is the most likely diagnosis? Entropion, dermatocalcisis, involutional ptosis, ectropion. Involutional ptosis results from a dehiscence or disinsertion of the levator aponeurosis. This ptosis is accentuated on down gaze in many patients, resulting in further closure of the ptotic eyelid. These patients not only lose the superior visual field in primary gaze, but also note visual field impairment in down gaze, since the eyelid rests in a lower position. Some patients with normal palpebral fissures in primary gaze have ptosis with down gaze. Entropion could conceivably cause difficulty in reading, however, ocular discomfort or pooling of tears would be expected. Ectropion and dermatocalcisis, unless excessive, are unlikely to cause problems with reading. All of the following are features consistent with double elevator palsy except ipsilateral hypotropia with large secondary deviation. Ptosis. Forced ductions indicating inferior rectus restriction. Chin down head position. Poor bell phenomenon on the side of the palsy. Double elevator palsy may be primarily caused by elevator weakness or restriction of the depressors. Ptosis, hypotropia, and poor elevation in any direction are characteristic. A subset will have positive forced ductions for the inferior rectus. Head position is generally an automatic compensation for the hypotropia, with the chin up. The most reliable sign that the orbital septum has been involved in a partial thickness lid laceration is ptosis. Orbital fat herniation. Entropion. Ectropion. Lid retraction in down gaze. Orbital fat is sandwiched between the orbital septum, superficial, and levator aponeurosis, deep. Critical components in the evaluation of corneal protection mechanisms prior to ptosis surgery include all of the following except assessment of log ophthalmos. Jones, primary dye, testing. Assessment of the Bell phenomenon. Schirmer testing. Assessment of corneal sensation. Jones testing will give information regarding patency of the lacrimal drainage system. Patients with positive Jones tests will have difficulties with epiphora, which can usually be managed independently.
Which of the following is a contraindication to Muller's muscle conjunctival resection? Acquired aponeurotic ptosis. Post-cataract extraction ptosis. No eyelid position change following installation of topical phenylephrine. Mild congenital ptosis. Muller's muscle conjunctival resection can be employed in the correction of blepharoptosis from a variety of causes. It is most predictably useful in patients who exhibit an elevation of the affected eyelid following the installation of phenylephrine eye drops. When planning to surgically repair a congenital ptosis in a patient, what is the most important preoperative assessment? Intercanthal distance? Levator function? Amount of ptosis in millimeters? Or eyelid crease height? The surgical technique used for congenital ptosis depends primarily on levator function. Patients with poor levator function often require some form of frontalis sling. The severity in millimeters of ptosis is secondary. Patients with marked ptosis and good levator function can still benefit from levator surgery. A patient presents with the obesity, a soft rubbery tarsus, watery tearing, and mucus discharge from one eye. He prefers to sleep in a face-down position. What surgical treatment would be preferred to improve his symptom? Horizontal eyelid tightening? Canthotomy of lateral canthal tendon? Canthotomy of superior limb of lateral canthus? Vertical shortening of tarsus? Floppy eyelid syndrome is characterized by chronic papillary conjunctivitis, easily averted, flaccid upper eyelids, and ocular irritation. Eyelash ptosis is common, and a marked decrease of elastic fibers in the tarsus has been reported. Ptosis rather than eyelid retraction is characteristic. The ptosis often responds to horizontal lid tightening. Vertical shortening of the tarsus is not typically needed. Canthotomies would aggravate the lid laxity which characterizes this condition. Canaliculitis has not been described, but mucus discharge is common. A 16-year-old girl presents with acute, bilateral eye pain, redness, and globe prominence, right more than left, with mild ptosis of the right upper eyelid. Both eyes have restricted motility in all fields of gaze. Blood testing reveals normal T3, T4, TSH, WBC, CRP, and ANA. Which of the following orbital CT findings would be most consistent with her presentation and lab results? Thickening of the posterior sclera and all rectus muscles including the tendons. Ethmoid sinusitis with medial orbital abscesses, right more than left. Fusiform enlargement of the optic nerve sheaths, right more than left. Thickening of the extraocular muscles, inferior more than medial rectus muscles, right more than left. Scleritis results in granulomatous inflammation of the sclera. Scleritis is not common in children. When present, scleritis is characterized by deep eye pain, pain with eye movement, ocular erythema, and mild ptosis. Serious retinal detachments may occur resulting in decreased vision. Scleritis is classified as either anterior scleritis or posterior scleritis. Anterior scleritis is further classified as non-necrotizing, which may be diffuse or nodular, or necrotizing, with or without inflammation. A 7-year-old boy presents for evaluation with a 1-week history of progressive ptosis of his right eye. In addition, he is noted to have ptosis of his right upper eyelid, erythema of the right upper eyelid, and right eyelid edema. On sensorimotor exam, there is 15 prism diopters of exotropia at distance and near. There is no history of fever, lethargy, or headache. Which one of the following is the most likely diagnosis? Retinoblastoma, rhabdomyosarcoma, orbital cellulitis, or metastatic neuroblastoma? Rhabdomyosarcoma is the most common pediatric orbital malignancy, exceeding all other sarcomas combined. The average age of onset is 5 to 7 years. The presenting sign is usually ptosis, which can develop over a few days. Strabismus and ptosis are also common. Biopsy is required for confirmation of the diagnosis when rhabdomyosarcoma is suspected, and CT or MRI should be obtained to help delineate the tumor to plan the best approach for biopsy. Early diagnosis and treatment of this tumor can be life-saving. Orbital cellulitis is commonly associated with ethmoid or frontal sinusitis. Early signs and symptoms of orbital cellulitis include fever, lethargy, eyelid edema, rhinorrhea, headache, orbital pain, and tenderness on palpation. When metastatic neuroblastoma presents, the clinical features vary according to the site or origin of the tumor. Pain, fever, and weight loss are common symptoms. Unilateral or bilateral ptosis and lid ecchymosis are classic presentations of metastatic neuroblastoma. The mean age at diagnosis of patients with neuroblastoma is 2 years. Retinoblastoma is the most common malignant ocular tumor of childhood. It is typically diagnosed during the first year of life in familial and bilateral cases, and between 1 and 3 years of age in sporadic cases. Onset later than 5 years of age is rare. The most common initial sign is leukocoria. Less commonly, patients present with vitreous hemorrhage, hyphema, ocular or periocular inflammation, glaucoma, ptosis, and hypopyon.